welcome back. Well, today I have Dr. Princenthal, who is here from RadNet, and he wants to talk to us a little bit about prostate cancer and some things that you need to be aware of. Well, Dr. Princenthal, thank you so much for being with us.
Thank you so much for talking about this important topic.
It definitely is. And, I think it's as far as I know, it is somewhat of a silent type of thing, correct?
Exactly. Most men with prostate cancer aren't aware they have it, and there are very few symptoms associated with it.
That's just frightening to find out that you could have something so dangerous and not have any idea. How do most men usually find out?
Well, fortunately, there's some excellent tools to allow men to identify if they're at risk for prostate cancer. Of course, number one is family risk factors. If you have a strong family history of prostate cancer, you should get checked earlier. There's always been controversy about the role of PSA blood testing, but by now that challenge should have been well put in the past, and most men over 50 should ask their primary care doctor to get a PSA blood test.
Okay. Now, is that something that they have to ask? I mean, it's not just a regular thing, because I know with women, it seems like we're always, especially over 40 now, oh, well, have you had your mammogram?
Well, men are a little bit in the dark ages, and unfortunately, insurance companies and the legislature haven't caught up. So women can request to have a mammogram without a physician's order. We're obligated to provide that level of care. But the challenge with the PSA blood test is they want men to have an informed decision and a discussion because of the potentials for false positives and false negatives. In my opinion, that stems from old-fashioned medicine. And previously, where we didn't have MR imaging to help guide biopsies and to figure out which men may harbor prostate cancer, the strategy was if your PSA is above 4, the urologist would blindly poke your gland with 12 needles trying to find cancer by chance. So that created some harms and false negatives. And clearly that strategy was not working well. So now what we have is, in my view, what men should do is get a PSA. If it's elevated or the trend is going up, then you can either do genomic testing, which is a 4K blood test, or a urine study called an exosome DX, again, to help strategize risk. And if those values are suggestive that they're abnormal, prior to any biopsy, most men should get a prostate MR, because frequently the PSA could be elevated due to infection, inflammation. If you've had intercourse recently before your blood test, or if you're a bike rider, all of those things can lead to a false elevated PSA blood test.
I see. So if they have an elevated blood test, then the next step would be to have an MRI, right?
In my view, that's the new strategy. And I think the AUA, the American Urologic Association, is now on board because we've made tremendous progress in improving the quality of the prostate MR so we can image the prostate gland in a similar way that women get with a mammogram. A mammogram, we can do a manogram and provide the same benefit of direct imaging of the gland with the prostate MR. So in my view, one of the main benefits of a prostate MR is its very high negative predictive value. If we don't see any abnormality, we can tell the patient with at least a 95% confidence they don't harbor any clinically significant cancer. That's a huge advantage. Conversely, if we see a lesion, instead of having the urologist blindly poke the gland to see if they can find the tumor, we can direct the biopsy and increase the yield of a positive biopsy with reducing the harms.
Okay, well, that's great. And then 95% is very high, so that's awesome. So is there alternative treatments these days for prostate cancer?
Yes, there's basically, we break prostate cancer down into 3 different groups: low risk, intermediate risk, or high risk. So for men who have low risk disease, which is defined as grade group 1 or Gleason score 6, typically it's small volume. Those cancers typically are low grade, indolent, and the old theory is that most men die with those prostate cancers than of it. So we manage those patients on active surveillance or watchful waiting. They don't need to have any definitive treatment. We just need to monitor them to see if they progress. For men who have high-risk disease, in other words, grade group 3 or Gleason score 4+3 or higher up to 10, those men should either consider surgery if the disease is contained to the gland, If it's beyond the capsule of the gland, they can have radiation with hormone blockade, both of which offer very effective control of the disease.
And then I think, well, from what I hear, RadNet is offering a different kind of procedure called the TULSA-PRO. Tell me what that is.
Exactly. So this is, in my mind, this is a game changer. For men who have intermediate grade disease, which is the majority of patients who need treatment, we can do whole gland focal therapy while leaving the gland intact. So what makes this technique revolutionary is it's done under MR real-time heat monitoring. So we have incredible precision to control the treatment boundaries, and frequently we can spare the neurovascular bundles and ejaculatory ducts to really maintain men's function after the treatment for prostate cancer, because that's what men are really more afraid of. They don't want to suffer the side effects of impotence or incontinence to have their prostate cancer treated. So with surgery, even robotic surgery, they've reduced those side effects tremendously, but there's still a certain percentage of men who have that. With whole gland focal therapy with TULSA, so the other thing that makes this revolutionary is the device is inserted inside the gland, so the treatment is from the inside out. The other types of focal therapy work from the outside in. They didn't have the precision, and there was a higher rate of recurrence. But for men who are eligible for focal therapy and want to maintain function, this is just amazing.
Is it possible that if somebody had already had a different kind of procedure, that a past procedure for prostate cancer, can they have this done again? Does it do anything different or no?
Great point. There is no harm or downside for doing TULSA. So in other words, if you've had TULSA first and you unfortunately develop a recurrence, you're still a candidate for surgery or radiation or retreatment with TULSA-PRO should you recur. TULSA is really one of the best mechanisms for men who recur. So if the man elected to have radiation and hormone blockade and has a recurrence within the gland, and they're not eligible for more radiation, most surgeons don't want to operate on a gland that's been radiated. So the best option for them is salvage with TULSA-PRO. And we have very good long-term data on that strategy.
How long has it been out?
TULSA-PRO now has 2 years of clinical data. It's passed the FDA milestone about a year ago. So it's now officially licensed and an approved treatment option. And we're proud to say we're the first and only West Coast treatment site for TULSA-PRO. There are a couple sites on the East Coast and in the Midwest. There's only 4 or 5 sites that are now open. We're opening this month and we'll be the first site on the West Coast.
Oh, okay. And which facility will that be available at?
That'll be at our RadNet site in West Hills, so centrally located in the greater LA market.
Well, excellent. Well, that is really good news, especially because you mentioned that it's the majority of men who are experiencing that mid-level. So I think that's awesome. Well, great. Well, thank you so much for the information.
And of course, we have a lot of information about prostate cancer and TULSA-PRO on our website, and hopefully you can get that link and get it posted. So if men have questions, they can find out how to contact us, and we'll be happy to provide whatever additional information they might need.
We will definitely do that. All right. Well, thank you, Dr. Princenthal. It's very nice to see you again.
Good seeing you again. Thank you so much.
You're welcome. And we'll be right back after this.